It'll take just a minute for us to get rolling here, but as our media partners are joining, I just wanted to introduce myself again. My name is Sharon Bogan from Public Health Seattle and King County. I'm pleased to be here again with you all. I was just reflecting a little bit with our media partners who've been part of this for so long. I appreciate you all being here today. And as we move into the long weekend, just a note of gratitude to you all that we've been working with here at Public Health for so long. And also just wanted to acknowledge today particularly that we're on the lands of the Coast Salish people, specifically the Duwamish tribe. And from there is where we are providing the briefing today. So as we move into the Day of Gratitude tomorrow, I'm personally thinking about that quite a bit. So thank you all for joining us today. We have a briefing with Dr. Jeff Duchin and Matias Valenzuela. Dr. Jeff Duchin is our health officer here at Public Health Seattle and King County, and Matias Valenzuela, our Director of Equity for Public Health. We're pleased that you are all here to join us as we hear about both the status of the epidemic here in King County, as well as some information about exposure settings. With that, I will turn it over to you, Dr. Duchin.
Thank you, Sharon, and thank you everyone for joining us today. I'm going to provide an abbreviated update on the status of our outbreak, and then we'll go into the briefing focusing more on the report around exposure settings in King County. To start, I need to acknowledge that cases and hospitalizations continue to rise in King County at alarming rates. Our cases are doubling approximately every 2 weeks, and we reached a new peak with approximately 700 new cases reported each day last week. That's 9 times higher than what we saw in late September, and about 3.5 times higher than the previous peaks we saw in the summer and in the original outbreak in the spring. We had close to 900 cases reported on the 19th. We are also seeing a sustained increase in hospitalizations, with our daily hospitalizations increasing 3 to 4-fold compared to October. That's every day, 3 to 4-fold more people being hospitalized in King County. For the last 3 weeks, we've seen between 100 and 160 people hospitalized per week, and that number was in the low 50s during most of November. We're also seeing a recent increase in hospitalizations among 80-year-olds and older, and among the 60 to 69-year-old group over the past week. And this is a very concerning trend for us because, as you know, previously, the majority of our cases and hospitalizations have been in the younger and middle-aged adults. Another worrisome sign, increasing numbers of outbreaks and the size of outbreaks that we're managing in long-term care facilities. We had approximately 61 outbreaks reported over the last 4 weeks, compared to 30 in the prior 4 weeks. And we had about 210 cases associated with these outbreaks in long-term care facilities during the past 2 weeks, which is a 3-fold increase from the 2 previous weeks. And as you've all heard, our hospital systems are stretched already, and they've activated emergency response systems, canceling some surgeries. And as one of our Washington State hospital leaders told us yesterday, these are joint replacements, heart valve replacements, and even potentially some cancer surgeries being canceled to make sure there's room for COVID patients. So as you know, and as you can see from these numbers, this is impacting us all across the community, and including our public health response. And it is absolutely terrible to contemplate that any one of us or our loved ones would not get the life-saving medical care that we expect if we need it. But that is becoming a real possibility, and we all need to understand the reality of that fact. And that reality means we need to get real with a serious all-of-community effort right now to prevent potential personal health and a healthcare system catastrophe and head off additional preventable hospitalizations and deaths. And this means taking all possible COVID-19 prevention steps in our personal lives, in our workplaces, and everywhere people gather in the community. We need to limit activities outside the home, limit activities to what is essential, avoid crowded indoor settings and poorly ventilated spaces, and wear masks whenever around others. With that, I'm going to turn now to our report on exposures, and it's important to understand the background in that report. I hope you please read it carefully and read the limitations in that report on what we can say based on this information. But in a nutshell, I'll just summarize that our investigators, in order to identify how cases might have become investigated, ask about activities during the 14 days prior to the onset of their illness through the 2 days prior to the onset. And we ask about things that are high risk for spreading the virus, such as contact in a group or crowded setting, activities in closed indoor spaces, spaces with poor ventilation, and close contact with someone with COVID-19. And in this discussion and in our report, we refer to these places and activities as exposure settings. Now, with respect to limitations, please read the report. There's a very good discussion of what we can and cannot say based on these data. I just want to remind everyone that we cannot always determine with certainty where or how someone acquired COVID-19 based on the information we collect. Many people have multiple activities where they could have been exposed to COVID-19. Sometimes people don't remember or want to share their activities with us. And it can be very difficult to find common links across cases with many activities, especially if they don't describe them in the same way to us. In addition, certain workplaces may detect and report outbreaks to us more reliably than others. So reported outbreaks do not necessarily reflect a complete picture of all the outbreaks or the number of cases that are associated. That said, for a subset of cases where there is a link to another case or outbreak, or only one suspected exposure setting reported to us, we designate a most likely source of infection, and we'll be talking about that in a few minutes. And I also want to bring to your attention that the numbers for November are incomplete and not reliable at this point. The case overload has made it difficult for us to contact all the cases and to do the extensive type of information gathering that we've done previously. So a word of caution about the November data. Okay, so getting into the report a little bit. Overall, a variety of community-based and social activities, household transmission, and essential worker status have been responsible for most of our cases. 29% of cases were among essential workers, including 17% among non-healthcare essential workers and 12% among healthcare workers. So I'm talking now about all potential exposure settings. This is basically whatever people describe to us that represents a potential risk for COVID-19 transmission. So in the last 60 days, 39% of our cases reported participating in a variety of community and social activities or gatherings, such as get-togethers with family and friends, dinner parties, birthday and other celebrations, Halloween parties and weddings, or visiting settings such as taverns, coffee shops, restaurants, retail businesses, places of worship. For example, 24% reported social events with friends or family. 15% of all cases reported visiting food service establishments, and 4% reported attending a place of worship. And again, this should be thought as a minimal estimate, a tip of the iceberg, if you will. The number of cases whose most likely exposure was associated with out-of-state travel increased to 8% in September and 6% in October, relative to 0 or 2% in April and May, when we had travel restrictions in place. I'm now going to talk for a minute about the most likely exposure designations that we made among cases in the past 60 days. 34% of cases had an exposure within a household setting that we thought was the most likely source of their COVID-19 infection. 21 had an exposure at a non-healthcare worksite or a place of employment. And 18% had an exposure linked to a community setting or social gathering other than a healthcare or workplace setting. And these include the types of get-togethers I described previously with family or friends, dinner parties, birthday and other celebrations, Halloween parties, weddings, visiting food service establishments or retail locations, places of worship, and other venues. 9% of our cases had an exposure at a healthcare setting. 1% were linked to an outbreak at a non-long-term care facility setting, and 3% were linked to an outbreak at a long-term care facility setting. And there are additional data in the report that I'm not going to have time to discuss with you, but I want to just briefly mention a few trends about most likely exposure setting within the last 60 days. And the trend graphs can allow you to track how things have changed over the course of the outbreak. So in the last 60 days, among our cases that are between 0 and 17 years of age, households were the leading most likely exposure setting. Among cases in the 18 to 24-year-old age range, community and social gatherings were the leading most likely exposure settings, followed by households. And among adults in the 25 to 49-year-old range, household and non-healthcare workplace settings were the leading most likely exposure settings identified. Both represented a similar proportion of cases. A larger proportion of cases in the 65-year-old and older group had exposure associated with healthcare settings relative to other groups. Many of these were residents in long-term care facilities. And finally, I'll speak a little bit about outbreaks. We identify an outbreak as 2 or more COVID cases linked to a facility or event. And since the start of the pandemic, we've become aware of and identified 836 outbreaks. More than one quarter of those outbreaks occurred at long-term care facilities with high rates of transmission and case fatality in the first months of the pandemic especially. We also identified 104 outbreaks in other healthcare settings, including 27 outbreaks at hospitals. Now, 31% of all of our outbreaks occurred in non-healthcare workplaces, most frequently at manufacturing work sites, such as construction and food processing, with 117 outbreaks, followed by 83 outbreaks at food service establishments. And finally, overall, 66% of our COVID-19 cases who were interviewed had close contact with another known or suspected COVID-19 case or were part of an outbreak. However, I think it's important to understand that 34%, approximately 1/3 of all of our COVID-19 cases, developed COVID-19 but did not know that they were exposed or in contact with someone with a confirmed or suspected COVID-19 case, and they were not part of a known outbreak. Now, in the report, you'll find data about exposure settings and how they vary by geography, age, and race and ethnicity. And these reflect different risk environments and activities across the community. And I'm going to turn the discussion over to my colleague, Matias Valenzuela, to talk with you more about that data.
Thank you, Jeff. We know that the pandemic has hit Black, Indigenous people, and people of color hard. These racial inequities are rooted in factors such as work, housing, healthcare access, wealth, factors that are impacted by structural racism that require deep investment and commitment to address. And that's why we have declared racism a public health crisis in the midst of a pandemic. This newest COVID-19 report shows us, once again, the important differences by race and geography that we see in health. In this case, we have seen especially hard impacts in communities of color in South King County, and see these differences play out in this report. At the end, where and how people live and work, their workplaces and households are important factors in exposure to the coronavirus. Not everybody has the same options to limit their exposure. If we take the most recent 60-day period, in terms of household impact, approximately 30% of all cases of residents who identified as Hispanic, Latinx, Asian, or Native Hawaiian Pacific Islander were likely exposed in a household setting. For workplace settings, excluding healthcare workers, Hispanic Latinx residents had the highest proportion of likely exposure in non-healthcare workplaces. In healthcare settings, among Black residents, and these are both patients and visitors, 15% of cases had likely exposure within a healthcare setting. This is higher proportion than any other race ethnic group. And then for community and social gatherings, white residents more often had community settings as a likely source of their exposure. That's by race. If we look by geography and we take some cities or regions of our county, for example, North Seattle and Shoreline area, 35% of the likely exposures are at community or social gatherings. That's more than double the rate for community and social gatherings in other areas of South King County, areas such as Auburn, Federal Way, and Kent. And when it comes to workplaces, again, these are often not optional settings. In North Seattle and Shoreline, only 13% of likely exposures were in non-healthcare workplaces, while the rates are almost double that in some of our South King County cities. So in conclusion, for areas like North Seattle and Shoreline, as well as in the white population, more common exposure settings are community and social settings. At the end, many of these settings are optional to visit. At the same time, there's a tendency for higher numbers of connections to workplace and households in many of our communities of color. We also see this trend in areas like South King County. We are reinforcing here what we have reported early on in terms of our racial inequities and why communities of color carry a disproportionate burden for COVID-19. Many people of color live in large or multi-generational households, which make it harder to limit exposure within households. They are also overrepresented among essential workers who have to be at job sites and commute during the pandemic. Also, let's not forget, many immigrant families have also been excluded from unemployment benefits and federal stimulus programs and payments, adding to the pressures of having to go and work in person. Sadly, many of our communities have had to make gut-wrenching choices between going to work in person so they can put food on the table or staying home and protecting their families. For us in public health, it's important to point out how these factors, how we live and work, as well as who has access to resources and wealth, are major factors, not just for COVID-19, but health and well-being overall. So we will continue, for example, preventing COVID-19 among our workers and at workplaces. We are providing resources to workers so they know their rights. We want employers to support employees in staying safe in workplaces and also to support those who must isolate and quarantine. Also, as King County, we continue to support in the house those who need isolation and quarantine, most recently adding a stipend program to support those low-income workers and families. So as we do this, though, we can't lose sight and also address the long-term issues, including structural racism and the corresponding deeply embedded inequities in access to opportunity and health in our region. So thank you. Back to you, Sharon.
Thank you very much, Matthias and Dr. Duchin. Now we have time to take some questions from our media partners. I'd encourage you to use the raise your hand function. And if you can start with asking one question, that will ensure that we can address as many questions as possible, and then we can loop back as time allows. So with that, I'd like to begin here, and I will unmute you. Let's start with Anna Boyko-Ryrak, and please also share your news outlet.
Hi there, Anna Boyko-Ryrak, KUOW Public Radio. Tomorrow is likely, unfortunately, going to be a day of some COVID transmission. What is Thanksgiving going to do to these numbers?
Thank you, Anna. I am very concerned, even afraid of what Thanksgiving is going to do to these numbers. I think there's a potential to see a dramatic increase even beyond the numbers that we're seeing currently in both cases, hospitalizations, and subsequently deaths. Very worried. And that is why we're asking everyone to please do whatever you can to understand the risk here, both to individuals and the community, and to understand that we're not asking people to give up Thanksgiving, and we're certainly not asking them to give up Thanksgiving next year or any years subsequently. But what we're asking people to do is limit the way you celebrate Thanksgiving this year, if at all possible, to the people you live with, and understand that every additional person that comes into the household or anyone who travels to attend a Thanksgiving gathering will introduce additional risk to you, your family, and your community.
Thank you. Evan Bush, you're unmuted.
Hi, I'm with the Seattle Times. Thanks for the opportunity. I'm wondering if the underlying data for this report will be made publicly available so people can take a closer look at some of the nuances here.
Yeah, Evan, I would like that to be possible. The data systems are very messy, so I will need to talk with our epidemiologists and see how we can do that. And I want to thank you and others for your patience. I know you've been asking about this information for quite a while, and I hope you find that what's in it is very consistent with what we've been communicating to you. But the challenges that our epidemiologists have been grappling with to integrate data from multiple systems, as you know, some cases are interviewed by the state health department, some are interviewed by our health department, and just the absolute volume of work and overload has made data quality and data management quite challenging. So I am supportive of doing that to the extent possible, that we can get the data out in a format that would be reliable and interpretable.
Thank you. Lindsay Sheldon, go ahead.
Hi there, Lindsay Sheldon with Cairo 7. Dr. I wanted to ask you about the support for departments to distribute the vaccine. You tweeted about that again last night. Could you talk about the kind of funding and resources that local health departments need to properly get that vaccine out to the population, and what the role is of a local health jurisdiction when it comes to distributing those doses?
Yeah, thank you for the question. In general, what I said about this yesterday is that it was very appropriate that we invested billions of dollars in Operation Warp Speed to develop vaccines. But with respect to preparing state and local health departments to actually deliver those vaccines to the public, it's been more like Operation Status Quo. We have a tremendous challenge ahead of us in organizing the systems to develop partnerships with healthcare providers and hospitals to get vaccine out in a sequenced way to priority groups as they're designated by the Advisory Committee on Immunization Practices, to develop immunization clinic logistics that take into account the risk of COVID-19 transmission, to monitor the supply of vaccine as it comes in and the need for 2 doses in populations, the data systems that are necessary to monitor inventory allocation, vaccine dose administration, and need for second doses. An incredible amount of work that needs to be done with the community on engagement around vaccine safety and concerns around vaccine uptake and equitable access, and putting systems in place to ensure the vaccine will be available to ensure equitable access and uptake. Those are some of the challenges that are being faced by state and local health jurisdictions. In all states, the CDC has charged state health departments with leading vaccine implementation and allocation planning. And in Washington state, we're in discussions with the state actively right now to understand how we're going to divide up the different roles and responsibilities. I do know that based on discussions with our team and with the Department of Health, that we need tens of millions of dollars in Washington state alone to meet the demand that we see to optimally be able to deliver vaccine to our communities over the next year or so.
Thank you. Simone Del Rosario.
Yes, thank you. And thank you, Dr. Duchin. I was wondering if you could tell me a little bit more, gauging your concern over these long-term care facility outbreaks. And, are we seeing sizable outbreaks again? And is there a concern about staff members being able to care for them when they're also impacted by this? Are we seeing staff who are asymptomatic that are still treating residents at these facilities?
Absolutely. Thank you for the question. So a couple of things. One is that most of our long-term care facilities have been screening their staff weekly in order to pick up asymptomatic staff members who might otherwise not be recognized until they develop symptoms and exclude them from the workplace. So that's a very good thing. That's been ongoing. However, no screening test is perfect. And we know that the higher the rate of COVID in the community, the more we all have it, the more we take it into our workplaces, whether those workplaces be long-term care facilities, manufacturing sites, food service establishments, or anywhere else. There is a lot of COVID out there, and it is inevitable that healthcare workers will introduce COVID into their workplaces, regardless of whether that's a long-term care facility or acute care hospital. So everyone needs to be vigilant for that. And that's one of the challenges that we're trying to address in getting the public to limit their activities to drive that rate of transmission down and decrease the risk for healthcare workers and other essential workers of introducing COVID into their workplaces. We are very concerned because we've seen a significant increase in both the number of facilities that are having outbreaks and the size of those outbreaks. Over the summer, we were very successful in limiting the size of the outbreaks through rapid testing and enhanced infection control measures that are still in place. But with the sheer degree of transmission that's happening in our community now, we should expect to see COVID being introduced anywhere and everywhere we go. And that includes our long-term care facilities. So again, reiterating the need for an all-of-community response here to protect the most vulnerable, as well as our own families, friends, and household members.
Thank you. And I'm going to pivot for a moment to a question from our community, from our Facebook live stream. And perhaps Matthias or Jeff, you want to weigh in here. But a comment about the longstanding inequities that we've seen by race and also by place in King County. And a question about what are some of the ways that the community now is working to address some of these inequities and any steps that public health may be taking to partner with communities.
Matthias, please go ahead.
I'm happy to start with that. I mean, part of it is we can't do this alone, and we, have some of the information, have some of the resources, but really we need a community-wide response as part of this. So we do have a pandemic and racism community advisory group that is about 40 organizations across sectors, and half of those are community-driven organizations, and they're connectors to helping spread the word. We just recently, in the last couple of weeks, got $500,000 out to also a group of additional organizations to address very specifically racial inequities in South King County and in communities of color. So this is us providing the resources and then having those organizations, that's close to 50 organizations and individuals and leaders, getting the information and for the Pacific Islander community, the Black community, the different various immigrant communities. We also have a robust group of community navigators and liaisons that have been our leaders that are embedded in community as part of organizations. And we've been increasing the number of people who are doing that work, and they're trusted messengers. They're from community, and they're the ones that are able to connect with people and provide the information and then tell us what is needed, what we need to adjust, what we need to change. But what part of the challenge here, and this is what we've been saying, is we do only so much with information, and our community has been taking extraordinary measures to get the information out. But sometimes when people are making some very tough choices or in very difficult situations, there are things that also are just, you can't just message. These are just deeper issues, such as what's been highlighted in this report in terms of household settings or workplace settings. So we're trying to do things to minimize the inequities in South King County and communities of color. But again, we have to be thinking also long-term and some of the deeper issues that are involved here.
Thank you very much. Let's move to Charlie Harger. You're unmuted.
Thank you, Dr. Duchin. Charlie Harger, Como News Radio. I would appreciate it if you could perhaps describe where we're at right now with the increasing hospitalizations and the lag of a few weeks before we unfortunately see deaths increase. How bad might this get?
Well, thank you for your question, Charlie. Like much of COVID-19, it's hard to predict precisely where we're headed, but all indicators right now in King County suggests it's going to get very bad, particularly if people gather in significant ways over Thanksgiving or subsequently, and if we don't do something differently. As you know, we've been asking, providing information and asking the public to limit their activities and take steps to prevent COVID transmission for weeks now, yet we're still seeing a relentless rise in cases that is now being followed by a significant rise in hospitalizations, significant impacts on our healthcare system. So theoretically, if we don't get this under control, what we can see is the hospitals filling up. That means they're at capacity both in their critical care, intensive care units, and with the amount of staffing that they have, cannot care for critically ill patients who absolutely need that otherwise. And I don't know how else I can express it. That is about as bad as it gets with respect to the impact on our healthcare system, people not getting life-saving care that they need. And we're hearing about other hospitals in other parts of the country approaching that point now. So clearly, if the outbreak continues to progress the way it's progressing now, we will reach that point. I can't tell you precisely when that will happen, but we absolutely need to turn this around before then.
Thank you. Heidi Grover, you're unmuted.
Hi, this is Heidi Grover from the Seattle Times. I'm wondering about public transit. We've seen an uptick in positive tests among employees at a few local agencies, and I'm wondering if there's any effort to track spread specifically among transit workers, or anything you can say about how that industry compares to some of these other essential jobs.
Thank you for the question. I do not have data on transit in particular, and I do know that we're seeing cases reported from, as I said, across the community, from every type of workplace. We're seeing outbreaks, as you can see in the report, from multiple sectors. I would need to work with our team and see if we've heard anything in particular about transit. I mean, clearly, any enclosed space presents special challenges which need to be met with increased ventilation, distancing, and masking. But I'm not aware of anything in particular that's going on in transit at the moment, and we'll check with the team.
Thank you. We have some follow-up questions, it looks like, so we'll go ahead and start with Evan Bush. You're unmuted.
Thanks so much again with the Seattle Times. Dr. Duchin, I'm curious, the testing access early in the pandemic might affect how this data presents. How much of this data and the trends that you're seeing as far as households and let's say healthcare settings, how much of that do you see as a real increase versus just an increase of who's being tested and who's being evaluated for COVID-19?
Yeah, it's a great question. I mean, there are a lot of things that impact, how we hear about cases, to the extent that we hear about cases and where we hear about them. Initially, with the outbreak focused in long-term care facilities, that's where most of the testing was happening, and testing access was limited throughout the community. However, I'm confident that the trends are pretty reliable because we didn't see, they're consistent with our hospitalization trends. So for example, where we see trends increasing in numbers and we see hospitalizations tracking. If we had seen hospitalizations going up without detecting cases going up in the community, that disconnect would have led us to wonder whether we were missing significant transmission in community. But the fact that you raised, that people may not have been seeking testing, or testing may not have been available as widely across the time course of the epidemic, and how testing access changes and testing patterns change, clearly impact what we detect, as does the issue of restrictions. So early on in the outbreak, we had stay home, stay healthy. And so people were not in workplaces, many workplaces were closed and so on. So, you have less opportunity for workplace outbreaks, and in some sectors in particular, the non-essential, and less people moving about in social or community settings. But during the entire course of the outbreak, we ask about various activities. And so the proportions of people who report the different activities should be relatively reliable. I mean, things do change also with our data systems. We bring on new case investigators. At times we can ask more thoroughly about people's activities. When we have fewer cases, we can do more investigation and investigate more thoroughly the ones that we do hear about. But as you can imagine, with 900 cases a day, 800 cases a day, we're quite overwhelmed, and we're not able to spend as much time gathering information from the cases that we do learn about. So your question is spot on, that there are a number of limitations in interpreting this data, and the points you raised are among them.
A shift now to another community question. This is a Seattleite who is now in Australia, and obviously we are watching what is happening globally and trying to learn lessons across the globe. The question is, why doesn't King County follow another approach, which is happening in Victoria, Australia, which is fully lock down and borrow money to provide basic income? So this gets to a policy question, but any perspective on that, Jeff?
Yeah, well, I think that we all recognize how COVID spreads. It spreads when people are in contact with one another, and fully locking down and preventing people from being in contact with one another is the most effective tool. However, it comes at tremendous cost. And we absolutely need to have economic support for those who are impacted by any restrictions, either in the workplace setting, be it owner or employees of workplaces. So this is something we're trying to balance now. You know, the availability of support for our community, the economic impacts of restrictions, and the need for restrictions. Whether we need to absolutely stop all activities or a subset of activities. But you're right that countries that have gone to full lockdown with support of their citizens and of their businesses and their economic sector are doing something that I think we would like to be able to do here.
A few more follow-up questions. Simone Del Rosario, you're unmuted.
Thank you, Dr. Duchin. You said a little while ago that you've been warning people for weeks about the increase in transmission, and yet they continue to gather. This is really our last chance to reach people before they either elect to gather with family tomorrow or agree to stay just in their household. And I know a lot of people will adhere to your advice, but there's many more who will not. How do you feel when you've continued to raise this alarm and hear that people are still going to continue their gatherings?
I think about this a lot. All of my public health colleagues think about this a lot. My colleagues in healthcare and on the front lines, dealing with the real impacts of this epidemic, with the human illnesses, the suffering, what it's doing to our communities, think about this a lot. Why are we as a society continuing to do things that cause terrible personal pain and suffering, that cause a tremendous amount of preventable illness and economic costs? And it leads to tremendous disappointment, frustration, across the board. It's hard to understand, but I think one way to think about it is that our society in many ways values individual liberty over societal good. And this is a cultural and social tradition in the United States in many places. And I think we haven't had to come together as a community to the degree that we really need to do so now. And it's something a lot of people just aren't used to and comfortable with. That, coupled with just the difficulty of the COVID-19 prevention measures and the duration that we need to adhere to them, the endurance that we need, that's quite understandable. I mean, I understand why people are getting fatigued. I understand how hard this is. But I also wish that people would be able to themselves understand the need to accept that relatively short-term discomfort and pain and endure through these difficult measures so that we will have a better long-term outcome with more people surviving, with less damage to our economy. And we've got what appear to be highly effective vaccines on the horizons making me feel that this spring we will be entering a phase where we'll be finally potentially be able to control this outbreak on a more sustained level. But clearly we have to get through this very difficult winter first.
Thank you. And I know both Jeff and Matthias mentioned this in our Public Health Insider blogs about the actions that we can take to reduce discretionary activities, given those that don't have that option if they're doing essential work in the community. Matthias, is there anything you wanted to add about that?
Well, I think it is important to recognize that workers do have rights, that you should be able to isolate and quarantine when it's necessary. And we want employers also, I know many of them are cooperating, they're doing the right thing, but we also want workers, because we have heard of situations more anecdotally of where people are having a hard time staying home and are fearing reprisals. So want to make sure that people know and workers know that they also have rights. And we also are very thankful and encouraged by the business community and everything that they've been doing to support workers. But there's still some situations that hopefully we can get everybody in line to really know that when we stop these transmissions in some of the workplaces, it's actually for a greater good, as Dr. Jeff Duchin has been saying.
Thank you. And I think we have time for one more question, one more follow-up. Anna Boyko-Wyrock, you're unmuted.
Hi again. Talking about the household exposure, since it is the largest source of, or most likely source designated, what does that indicate about the success of the county's quarantine and isolation facilities as being a place where people of color, for example, want to go to get out of the house so that they don't spread the virus?
Well, I can start, and then maybe Matthias may want to add as well. But this virus is incredibly widespread throughout our community. And although many infections can be spread in the household, and the household has been shown through research to be a high-risk transmission venue, there's always, someone who brought it into the household. And so not all infections aren't, generated de novo in the household, they're spread in the household. So people acquire these infections from other people in the community. They come home into the household and then they can spread to other household members. Many household members do not choose to go to isolation quarantine. They prefer to stay with their family, or they cannot leave their family. So there are issues in that sense. And there are also issues around the fact that this virus spreads very quickly before people know they have symptoms. So for example, by the time we reach a case, just the few days that are necessary for the case to realize they're sick, to seek testing, to get that test result for us to contact with them, that's already spread to several household members. And so we're really mostly looking at that third generation of spread interrupting and focusing more on the community members, because this disease spreads so rapidly. The generation time is so quick that in most cases, by the time we reach a household, the household members that have been infected may already be symptomatic or infected. I'll let Matthias also comment on what factors that might lead household members who are exposed but not yet ill to accept quarantine.
So I think Jeff hit it too. I know it's an important, the isolation quarantine sites are very important for the homeless community, most definitely. And we do have, and we talk to some of our community leaders and people who are talking to those who have the option to go to some of the locations, and they talk about the challenges in terms of actually doing that. And we've done efforts like the site out in Issaquah that will handle families. And I think still with that, the preferred method that we're hearing, at least from community, is often to be able to isolate and quarantine at home. So I think all the other support services that are offered in terms of food and other things that people can get in their household is extremely important. But at the end, I think some of the issues that Jeff Duchin was just mentioning about asymptomatic individuals and other situations make this extremely complex.
And I would also add that these isolation quarantine facilities are especially important for people living in congregate settings because there's more people vulnerable there and the risk of spread is much greater. But we do have very high occupancy in our isolation and quarantine facilities. Nonetheless, even though we have lots of household transmission, we still have many people taking advantage of those facilities, and theoretically that is preventing even more spread in the household and in the community.
Thank you very much. It looks like we're having just a little bit of background noise, but Matthias, I'd like to turn it over to you for any last thoughts or words, and then we'll also turn it back over to Jeff.
Yeah, I mean, I just think it's extremely important as we think about inequities. It's not just thinking about the communities of color or South King County that are disproportionately affected. It's what everybody else can do to actually support this. So there's some long-term things, but even around when there are things that are optional that people don't necessarily have to do, just when we think about some folks that don't have a choice and do have to actually live in certain household settings or do have to go to work, that means the greater responsibility for other people to do their part. Because sometimes we think, okay, what can I do? But the more that we can actually have everybody else follow some of the, follow the restrictions, stay away from gatherings, those kinds of things, it will reduce the amount of disease in the community that is affecting everybody. And then we'll also help reduce the numbers of infections that we see in our most impacted communities. But there's this direct correlation, and this is what everybody can do in terms of coming together to support the well-being of everybody.
Thank you. And Jeff, any final thoughts?
Thank you, Matthias and Sharon. Thanks everyone for joining. I want to just reemphasize that this outbreak has gained tremendous momentum at the moment, and it is going to continue to impact us for weeks, even after we change our behaviors and start doing what we need to do to decrease transmission. Folks need to realize that this is not something that is a problem for only those who have social gatherings and community gatherings. It's not only a problem for household transmission. It's not only a problem for the workplaces, restaurants, for manufacturing, for faith-based places of worship where we've had outbreaks, but this is a problem for all of us. This is an all of community public health emergency, and we all need to step up and play our role in protecting one another. Thank you so much, and I hope everyone has something to be grateful for this Thanksgiving. I'm certainly grateful for the work you're doing to help us get the word out.
Thank you very much. Good afternoon.